I like what the others do because they look very happy.
So are you saying gynecology is not a happy place?
It is, but it in our setting, I think the doctor carries a really large burden of that particular process. But that's not even the problem. We're equally dying as much.
Yes. Yeah.
So for every one person you diagnose, it's almost like one person will die.
What are we getting wrong?
We are not investing in prevention. It's a money problem. We really need to invest in prevention. Not treatment has a role, but really the money has to come here. People are people.
Yeah.
They're not
their diseases. Yeah.
And I've been asking myself, why are we downstream the problem? Why can't we just vaccinate? Yeah, let's just vaccinate. I think we'll solve a big problem that we are trying to solve. That why are we spending so much money on PET scans?
Hi guys, welcome back to A Dose of Health, the podcast where I give you not too much, not too little, but just enough health information to make you make an informed decision. Happy New Year, by the way. Happy New Year. Happy 2026. So our year started in February and it was very intentional. Coming from an event in December and just a whole year of having episode after episode. So we took a break in January, but we are back. We're back, baby. We're back. And we're back with so many lovely guests, so many lovely conversations. And we want to engage with you guys a bit more this year. So let me just start off by saying, if you've reached here and you haven't subscribed, please just press the button. Just press the button. I'm giving you time. Okay, so subscribe, follow us on YouTube, on Instagram, on LinkedIn, on TikTok, wherever we are. Please just engage with us and let's have a good time this year. Let's converse and yeah, let's go. So I have a lovely guest today and coming off of a very active January. In case you didn't know what we celebrate in January as a health fraternity, you'll know the guest here that's very inclined in the field that she's in. And I just want to introduce her briefly, but she'll do it justice herself. So I have Dr. Masinde here with me. She's a gynecologist, and she's here to talk about cervical cancer awareness. So let me just let you introduce yourself a bit further. And yeah, I get to interact with our audience.
That's nice. Thank you. So my name is Millicent Masinde.
Doctor,
yes. I am actually a medical doctor. I've been practicing for almost 20 years. You wouldn't believe.
Stop, 20?
Yeah, I'm just about to clock 20.
Wow.
Yes. And yeah, so that's been a journey. Yeah, I've been in school a good portion of that time.
Oh, to be a doctor?
Yeah, it's been a long time.
Yeah.
But yes, now I'm a gynecologist. What does that look like? So...
we know it. We'll get there. Don't answer that.
It's a very long journey.
Yeah.
Yes. But yeah, I'm happy to be here.
Okay.
And yes, January was Cervical Cancer Awareness Month. And I'm hoping everyone's screened.
You know, I'm just realizing you're in blue. Was this intentional?
No,
it wasn't
it's green.
It's green blue.
Yes. So the actual color for awareness for cervical cancer is teal and white.
Yeah.
Yes.
Okay.
Yeah.
So I hope we all screen, by the way. She said that. If you didn't, the clock is not running out. You still have time. Throughout the year, you can still screen. So before we start, we usually have a segment called A Journey to Inside Out. I just want to find out where you are, how you are. So there's a movie called Inside Out. Have you watched it?
No.
You haven't watched it?
I should watch it.
You should. There's one and two, Kwanzaa.
Really?
Yeah.
I will watch it.
Okay. So in the movie, they basically talk about emotions, how we behave, the way we behave and why. So I just wanted to find out mentally, how are you today?
I'm in a better place. Yes.
Okay.
January was pretty heavy with work, with home, just because I was running a campaign in January where I work and just having the messages out, still working and doing all the parallel stuff. That was intense.
Was it on social media?
It was on social media. That's how we had cervical cancer screening. We did HPV testing for free, which was good. And people know.
Yeah. So now we can actually say social media is work, yeah?
It is work. It is work. Yeah.
And it's a lot of it.
It is a lot of work. Okay. That's true.
So it's lovely that at least you're in a better space right now. I think for me, excited just because we're back and I love having conversations with specialists and just people who have been in this space for a longer period of time. I'm also a student, so I learn. Every single day I sit here with a guest, I learn something.
Yeah.
Yeah, so I'm excited to be back and just looking forward to the conversations we're going to have.
Yeah. I don't think there's any conversation lost.
There's none.
Yeah.
Yeah,
You
there's none.
can always learn from someone.
Exactly.
Something new.
And we see as a doctor, you're forever learning.
That's true. Does it ever end?
It doesn't end. And first of all, we need to slow down.
Yeah.
Things are happening so fast.
Yeah. You have to be
We need
intentional.
to just slow down.
Yes, you do have to be intentional to slow down.
Yeah.
Because if you don't know this, then you want to learn it. Then when you learn it, there's another new thing. Then AI comes, then we have to learn everything else that we have been learning in AI language.
AI,
so
it's
intense. It's intense.
Hey. Anyway, speaking about learning, let's step into the doctor's seat. They're just random questions. Don't overthink them. Let me start with the first one. If you had to explain what you do to a 4-year-old, how would you describe it in 1 or 2 sentences?
Yeah, that's a good question because my 5-year-old asked me that question one day.
How did you explain it to her or to him?
So I go to hospital to make sure that sick people feel better. And the ones who are not sick, not to get sick. That's what I do. Yeah.
Okay. I like how it's vague. It touches on like, if you're sick, go to hospital.
Yeah.
Even if you're not sick, still go to hospital.
Still go to hospital.
Okay.
Yeah.
Okay. Then the next question is, if you were to rate your top 5 medical specialties minus yours, which ones would they be and why?
If I was to?
Rate your top 5 specialists from
if I was
1 to
rate
5.
them.
Yeah.
Or the ones like happiness.
Whatever it is.
Unfortunately, it would be like all my colleagues who look very happy.
Start. Minus yours.
Minus mine.
Yeah.
I think I would do dermatology.
As number 1 or number 5?
Number one would be dermatology. I think dermatology has a sense of happiness. You can dress in a very happy manner. You don't have to worry about a 3 a.m. call is rare. Not every day.
Yeah.
And then I would do like rheumatology.
Okay.
So rheumatology has its own things, but I think it's enjoyable.
Yeah.
Then
before we continue, maybe someone doesn't know what rheumatology is.
So the guys who deal with inflammation of the joints. Yeah. So like joint swelling and autoimmune, like the immune conditions that, happen when the body is rejecting itself in some way. Yeah.
Okay. That's number 2.
So rheumatology is nice. I also think it's nice.
Okay.
Yeah. Then I would do gastroenterology.
Interesting.
Yeah.
H. pylori. You and H. pylori are just like...
we eat every day.
Oh.
Yeah. So that would be nice.
Okay.
Yeah. And number 4?
Number 4?
Number 4, I need to think what number 4 would be like. Apart from what I do.
Yes, apart from what you do.
Number 4 would be like pathology. Yeah. I think especially the guys who do like clinical chemistry, hematology. I like that part.
Okay.
Yeah.
Okay.
I think they're happy people.
Yeah. They're it's like you're only called if.
Yeah. Exactly. But the one I really love the most, you won't believe, is actually lifestyle medicine.
Is that a thing here yet?
Not yet, but I really like I've loved it all through my work.
Yeah.
Yeah.
Well, really? That's interesting. So is it the highest on your list or it's like number 5?
No, it's the one I like for myself.
Okay.
Yeah, for myself. I like what the others do because they look very happy.
So are you saying gynecology is not a happy place?
It is, but it in our setting, I think the doctor carries a really large burden of that particular process. Like, for example, if I give someone a cancer diagnosis, I need to know whether they can afford it, afford treatment. I need to know what their social surrounding looks like.
Support, yeah.
Because if they're alone, then it means I need to be sure they can handle it. Then also just the tests coming back, what is their mental space like? So I end up counseling them for their mental space. I end up counseling them for their diagnosis.
Yeah.
I end up counseling them to ensure they have social support. I think that is heavy on what we do.
Yeah.
But just doing the one part, like you have a cancer diagnosis, we can do this and that, and you can get better, that's fine.
Okay.
That I can deal with.
Yeah. So you're saying that we need to put the multidisciplinary in the word.
Yeah. We really need to move from all that. Then there's the aspect of nutrition. I haven't told you how hard it is.
Were you there when? So we actually who is the camera? Who is there? My camera.
Yeah.
We attended a symposium on cervical cancer elimination, and we had people with lived experiences. And one of the survivors actually said one of the most neglected aspects is nutrition. And I was just like, it's so true, because you need to be nutritionally healthy to be on chemo. There are some times where you're on chemo, you can't eat. Then if you're not healthy nutritionally, you can't get the... I was just like...
It's a vicious cycle.
Oh my goodness. Yeah. We really need
and
to.
And that's why I like lifestyle medicine.
Okay.
Because it's really wholesome.
Yeah.
And it gives you an opportunity to prevent illness and to be able to treat illness.
Yeah.
Yeah.
Ding, ding. That's why we're here. Prevention is better than cure.
Prevention is so much better than cure.
100%. Okay. So when lifestyle medicine comes, it's first contender.
I'm not waiting for it to come. I've been saying this for a long time. I think I'll just do it.
In whatever way or form you can.
I will do it.
Yeah. All right. Then the next question is, if you won a grant today, imagine however much you want. Put a number. What problem are you solving?
I have actually had a grant.
What problem?
So, I've changed my mind lately. Like in the last 2 weeks, or rather the last 1 month, I've listened to a lot of cervical cancer things.
Yeah.
And I've been asking myself, why are we downstream the problem? Why can't we just vaccinate? Yeah, let's just vaccinate. I think we'll solve a big problem that we are trying to solve down. Why are we spending so much money on PET scans? I know there's a population that's already there, but why are we not spending a lot of money downstream or upstream to ensure that we don't have to do so many PET scans in the next 20 years? Yeah. So it would be definitely something to do with vaccination.
Okay. I like that. I like that. And I'm 100% for it. And I think it's the element of preventing the fire before it starts, so that we don't have to put it out anyway.
It's so much easier. After doing all the many complicated surgeries because of cancer, I'm beginning to think prevention is really better than cure. It's cheaper than cure. It's more mentally acceptable than cure. It's less, it's when you get to the cure side, it really affects a family so much. You start wondering, what's really the point of the thing I do that I do every day?
And cancer is it's so heavy.
Cancer is very heavy. It's very, very heavy on our family. It's not cancer is not an individual problem. It never is. It's a diagnosis that has so many ripple effects. If you're the breadwinner, we are saying that we are not sure how people will eat.
Exactly.
We are not sure whether they'll have shelter, whether they'll go to school. And those are basic things,
Yeah. And that could start as soon as today. Like immediately we start your treatment, not at you waiting for it to get worse. And unfortunately, let's say we lose you. It's immediate.
It's immediate.
Yeah. Okay, we'll get to that. Next question. What's one skill or habit you feel makes you a better doctor?
Well,
let me say a good doctor.
A good doctor.
Yes.
Actually listen and check up on my patients.
Oh, okay.
Yeah.
Okay. Listening is a good one.
And I talk to them about other things, not about their illness and all that, like how your kids doing. I've been invited to their functions, a good number.
Do you go?
Sometimes.
Okay.
Sometimes I can't make it because of other things. But yes.
Okay.
I actually had a patient who was leaving the country yesterday, and she called me and told me, I'm relocating.
That's like one of the sweetest messages, because you're just like, it's like
I'm
a pat
so
on the
sorry
back.
I didn't come to see you, but I'm relocating and I'll call you when I get there. I will be calling you.
That's really nice.
Yes, so that's nice, because that's outside medicine.
Yeah.
Yeah, so by the time someone can get to the point where they can tell you, their everyday story outside medicine, that's a good thing. It actually makes health very wholesome.
Exactly.
And I like that.
And I think it also shows you're looking at them as a person and not their illness.
Exactly.
Yeah. Which is something we need to learn. You remember in med school, you're just like, so where's the TB? Oh, the TB is in room 5.
Imagine I never let that happen.
It's just like we need to
No. I actually never let that happen. You really have to, like, if I'm doing a word round with you, you can absolutely not say, this is vulval cancer. You can't.
Yeah.
You have to say, this is Millicent. She's been here for 10 days. We've been treating her for this.
Yes.
Any other way, you will start from the beginning again.
Go back.
People are people.
Yes. They're not their diseases. Yeah. Okay, now before we start the episode properly, today is Wednesday, so there's something called Swahili Wednesdays. Ukitumia lugha ya taifa, tueleze mada ya leo na dalili zake.
Mada ya leo ni saratani ya si njia. Sio njia. Inaweza kuwa njia ya kizazi ama mlango wa kizazi. Yeah. Njia ya kizazi ni cervix, vagina, vulva. Lakini mlango ni cervix, vagina, vulva, but njia ni cervix.
Okay. Yeah. Okay. Dalili moja ama 2, 3 hivi?
Inaweza kuwa ni uchungu. Kama imeenea. Kama saratani imeenea. Kama imeenea, kuna uchungu.
Okay.
Kunaweza kuwa na uvimbe kwenye miguu. Ama kunaweza kuwa na uchafu unaotoka katika njia ya kizazi.
Okay. Makofi kwake. I said every guest is going to speak just some small Swahili.
I agree.
Kidogo to Swahili Wednesdays. Yes. All right, now let's just go straight into the conversation of the day. Cervical cancer. Why are we talking about it over and over? Like at some point you sounded like a broken record. Why are we talking about it over and over and over again?
Because so there's this map that shows where cervical cancer is. I should give it to you.
Yeah, we'll try and put it
somewhere.
Yeah.
And every time I look at it, sub-Saharan Africa is the darkest. It's really, really dark. And so our incidences of cervical cancer are really high.
Yeah.
But that's not even the problem. We're equally dying as much.
Yes. Yeah.
So for every one person you diagnose, it's almost like one person will die.
Wow.
Yes, and we don't want that.
Yeah.
And when you look at it, essentially, if you're having about like a 6,000 diagnosis per year, and then you're having 5,000 and something die, what's the point?
Almost 80%.
Yeah. What's the point?
Yeah.
That's like we didn't do anything.
Yeah.
And the question is, did we? Did we actually do anything?
Because in other countries, people are not dying as much.
Yeah.
So what are we getting wrong?
We are not investing in prevention. It's a money problem. We really need to invest in prevention. Not treatment has a role, but really the money has to come here. I like what guys do abroad. I really do. Because when you arrive, like it's your week 1, they'll send you a mail to your door. You need to be screened for cervical cancer. A month later, if you haven't, someone will call you. And another month, if you still haven't gone, you'll be called by the doctor in your area.
Yeah. Like, hello.
They're not joking. You're coming in. Yeah. That's what they're saying.
Because now it becomes a burden on the system.
Yes.
Yeah.
Yes. So they call you. But you ask yourself, how best can we replicate that in our system?
Yeah.
We had a Nyumba Kumi initiative. And so why are we not using it to enhance screening?
Tell us more about Nyumba Kumi initiative.
So Nyumba Kumi was where I needed to know 10 of my neighbors.
Oh, I've already failed. Like I know them, but I don't know them by name.
Yeah.
Okay.
I don't know why we are doing that anymore. But we knew all our neighbors when we were growing up.
It's true.
Yeah,
you're
so
like, I'm
what
going to Nani's
happened?
house.
Yeah, what happened?
I don't know.
Yeah, something happened. Something really happened. I think
Yeah.
we moved from community to individualism. And it's very sad because you may not know your next door neighbor, like literally.
Yeah.
Yeah, but if we live in this particular community, it's easier for us to, you know, to have like a social Sunday where someone comes and says, okay, screening is very important, vaccination is very important. Can we have this happening? The men can ask questions.
Yeah.
They can understand why we are pushing this agenda. It's not a woman problem. It's it's a country problem.
Yeah. Okay.
Yeah. So we can use the systems we have in existence to be able to push for prevention.
Yeah. I think this is a call to us. At least go and know at least 10 of your neighbors.
Then your social Sunday can have a theme, you know.
Or even if you're going for testing yourself, you can call up your neighbor and be like, oh, by the way,
there's free
have
testing
you done
or
yours? Exactly.
How will you tell your neighbor if you don't talk to them?
And then that's not like a topic that you're just shouting like that.
Exactly, but it's easier when you know each other.
Exactly. Okay, I think that's a very good place to start. But now you've talked about other countries. In terms of prevention, first of all, what country, are there examples? I know Australia is one of those countries. What other country is doing well in cervical cancer prevention?
That in Africa, their country is doing well.
I'm so happy. You know, when I hear Africa, yes.
Rwanda is doing a good job.
Rwanda, like that's
Eswatini is doing a good job. Imagine Eswatini is doing a good job.
Is that why they received lenacapavir first?
Maybe because they are more organized or they're accepting change quickly.
I think so. Okay, that's good to hear.
They're doing a good job. And I looked at it and I wondered, what's really our problem? The blueprint for how to actualize this, we have it. They're borrowing our ideas,
our policies, yes,
on how to actualize cervical cancer elimination. So what's really our problem? That's why we go back to what is our sociology around medicine? What's the problem? You know, why
we don't have sociology around it's missing.
Why are we not able to actualize these things?
Yeah. What has Rwanda done?
So for Rwanda, they're vaccinating. I think they've even reached catch up because they were at I think 90% already.
90%
or 92% vaccination.
Wow.
Yes. Wow. They're vaccinating every girl.
Yeah.
Literally.
And you know, actually, there's this notion that let me say it's misinformation because I don't think people are just spewing out information like this from a bad place, that the vaccine is not safe, that it has heavy metals like mercury. What's your take on that?
Imagine that's the story that has been going on with like every vaccine.
Yeah.
And you see, when the HPV vaccination was actually introduced, it's the narrative around HPV itself that made it very difficult. Because one, we were saying we were vaccinating girls. So are girls sexually active? That's the question.
Yeah.
So why are we going down? Why can't you just give the people who are sexually active? But you see, it's more useful before any sexual encounter. That's when you can form a good immune response.
Yeah.
But so it's a cultural problem.
Yeah.
We said we are vaccinating girls. The girls were the ones who are not sexually active. So there was a resistance towards that.
Yeah.
Yeah, but we should work on that. The conversation around HPV vaccine, we've come a long way. We really have, yeah.
Do you think messaging has been a problem?
Messaging has been a problem. Even just how we packaged HPV is not the same way we package pap smear. You realize we don't shudder when you hear pap smear.
Well, they do. Let me show you why they do.
Oh, really?
Let me show you why they do.
People don't like
this
shudder so much.
This thing. Doc, this thing has women closing their legs whenever they see it. When they hear pap smear.
And it's true. There are two women who tried to change the...
Yes.
I'm looking forward to seeing it.
Can they reach here?
You know?
Yeah.
Yeah, we want it
the women-friendly pap smear. Yes. I mean, speculum.
Yeah, so the pap smear, the biggest problem has been the speculum.
Yes.
Just inserting that particular speculum. But aren't we making it easier with the HPV self-test?
Yeah.
Yeah.
Okay. Now, I know we're talking a lot about HPV. Why is HPV and cervical cancer, why are they always in the same sentence?
And that's a good thing. I actually like that we finally had a cause. Because I guess when research was beginning, so many women were dying and the explanation around it was just not clear. So the discovery of HPV made it easier to see that, okay, this problem has a virus involved and we can actually cure it.
Yeah.
So what do we do? Of course, we start with treatment because it was initially the lesions that people are seeing on the cervix. But HPV, human papilloma virus, in essence, is a virus that affects the cervix. And so the problem is not really acquisition. We say that by the time people are in their 40s, about 80% of the population would have been exposed to HPV.
Yeah.
So the presence of HPV is not really the problem. It's the persistence of HPV that's the problem. Now, there may be risk factors around it, but sometimes we don't know who will persist.
Yeah.
And that's the problem.
Yeah.
So we don't know who will persist. Yes, there are issues around immune responses and immune suppression and all that. But at the end of the day, we know that the population that has HIV is at 6 times higher risk. But there are women in the general population who are still persisting.
Yeah.
And so the persistence is what leads to the precancer cervical lesions, then onward to cervical cancer if you do nothing. And you know what? That journey is like so long.
15 to 20 years.
It is so long, really. The idea that you can move from a HPV infection to a precancer cervical lesion, to cervical cancer stage 1, stage 2, stage 3, stage 4, and the system hasn't caught you, there's a problem.
Yeah, a big
There really is a problem. In that whole journey, they should catch you somewhere. Yeah.
Okay. And for HPV, is it that even if I have, because HPV has many strains, and we know there's the low risk, there's the high risk. So the high risk ones are the ones that have been directly linked to cervical cancer. What about the low risk ones, the 11 and 6, the ones that cause like the warts?
The warts. Yeah. So still the same thing. So and why the vaccine has the warts is because the warts are really hard to treat. Yeah, they're really hard to treat. Like you may treat them now and they'll still recur. It's like they're almost embedded into the system. So they can go down, come up, go down, come up. And it can get really, really bad. It almost looks like you have a cancer. Yeah. Okay. So it's not cancerous, but it's just fulminant, warts.
Yeah.
And that's preventable.
Yeah. To the vaccine as well.
Yes, that's preventable.
Okay.
Yeah, so in terms of the HPV types, the genotypes are more than 100. But the high-risk ones that cause problems are around 14.
Okay.
But the ones that are causing 70% of our problem are 16 and 18.
Wow.
Yeah. So if you have 16 and 18, then we really need to follow you up closely because the risk of progression is a little bit higher.
Okay.
Yeah.
So I normally get this question, since most of the time HPV, the infection, doesn't manifest with symptoms. So what does following up look like?
That's actually a good question. Even the precancerous lesions don't have symptoms.
Okay. So let's start from the testing. So you've done either a pap smear or you've done your HPV DNA testing. Let's start from there.
So so first of all, there are various ways you can test.
Okay.
So that's the first thing. You can do either the HPV testing. It can be provider-driven or self-tested. You can also do the visual inspection with acetic acid. That's provider-driven. And you can do the pap smear, which is provider-driven. Yeah. So cytology-based is generally the pap smear or the liquid-based. So in terms of screening, we have an array of screening modalities.
Yeah.
So any of them, if you have a positive test in any of those tests, then you need to proceed on to triage. Now, triage varies depending on resources. Yeah. So you can still do visual inspection for triage, and you can do colposcopy. And I guess colposcopy has been difficult to access because it's not in every area. But yes, it's available. So what that particular thing means is that so colposcopy is like the microscope that looks at the cervix. So it's a little bit so it varies. There are different types. There are big ones. Yeah, there are big ones and then there are small ones.
Yeah.
But ideally what it does is to be able to identify whether you do have any changes on the cervix, which are the precancerous lesions.
Okay.
So having a positive HPV test does not necessarily mean you have a precancerous lesion. You could have just gotten the infection, or you could be just having a persistent infection that has not caused any changes yet on the cervix.
Okay.
Yeah, so what that helps you to do is to be able to see at what level the precancerous lesion is if it's present. So if it's present, we have 1, so they're like 2, 3. So you have 1, 2, or 3, and the treatment varies depending on where you are at.
Okay.
Yeah. So like 1 essentially is like when you have the HPV infection, so the cells are just beginning to change, but 1 can revert to normal when the HPV clears.
Which is how long?
You give it like a year or two.
Yeah.
It will clear. Yeah. So in most places, we don't even push for treatment for the first one, CN1.
Okay.
Yeah. But 2 and 3 means we are moving towards cervical cancer. And it's unlikely that you're going to be like CN2 now and you have cervical cancer next year. So it still takes time.
Yeah.
And that's why we should treat at that particular point. So that's why screening and treating is actually important when you find a lesion.
Okay.
Then you have 3. So 2 and 3 need to be treated, and you still need to follow up.
Yeah.
But and then treatment is really simple for the precancerous lesions. Like I like what the treatment is like, and I like what the follow-up looks like because it's a day procedure.
Okay.
You just have maybe a portion of where the abnormal lesion is. It can be actually cut almost like a biopsy, or you can have it like burnt a little, just where the lesion is.
Okay.
It's not painful.
Okay.
Needless to say, I have to emphasize that it's not painful.
Yeah, and for real, you have to say for real,
real. For real, it's not painful.
Okay.
And there are modalities to ensure that it's actually not painful.
Okay.
Yeah.
Okay.
And we need to remember the cervix heals like the mouth. You know, like when you bite yourself.
Yeah.
So in the first days, you'll feel like there's something, but you will not feel it after a while.
Yeah, it just goes.
So the cervix is like that. After a while, no one will know.
So it will be fresh again.
It will look. You will not see if there's a problem.
Okay.
You see like when your wound heals.
Yeah.
In the initial times you feel like a bump, but at some point you no longer feel it. Same thing with the cervix.
Okay.
Yeah.
Okay. That's interesting. So how long do you follow an individual who's gotten HPV, one who has symptoms versus one who does not have symptoms?
So HPV and precancerous lesions do not have symptoms.
Okay.
Completely.
Interesting.
Hardly do you have a symptom.
Yeah.
Unless you have like another sexually transmitted illness or something like that, or just a vaginal infection for whatever reason. But up to cervical cancer, really, you should not have any symptoms.
Okay.
Yeah. Okay. And I think that's what causes our greatest problem, because we are cultured.
If you're not
to be seen,
if you don't
when
have
there's a problem.
Yeah.
So there are no symptoms over there, and that's why we screen, because you screen an asymptomatic population.
Yeah.
You don't screen, like if you come to me and you're already saying, I'm having bleeding, I'm also having a vaginal discharge, I'm no longer screening you. You already have the disease. We are not screening.
We're waiting to diagnose.
Yes,
something.
we are doing diagnosis now. So screening is for an asymptomatic population.
Okay.
Yeah. Then diagnosis is for already the ones who have symptoms. Then you're now looking for the diagnosis of this particular problem.
Okay.
Yeah.
Okay. So if I have HPV, you say there are no symptoms, how often should I come just so that we can see that it's cleared? I know you said it takes 1 year to 2 years.
Okay.
How often should I
come?
So
once you've had a positive HPV test, then we'll triage. If you don't see a lesion or anything like that, then we follow you up after a year.
Okay.
So a year later, you repeat the HPV test. If by the second time, so then if it's still positive, we go through the same mechanism. If I still don't see a lesion, then you come back a year after that. So now if it's persisting for a long time, then we need to take biopsies just to confirm that nothing is changing.
Okay.
Yeah.
Okay. Interesting. And now that we've talked, let me just put this aside. Now that we've talked about HPV and like how to screen for it, there's also another question I get. I know the vaccine is available for 10-year-olds as according to our national guidelines, and it's now a single dose. So you just need one shot and you're good for life. There's this question of 15 and over. What happens to them?
Okay, so now, the vaccine is free because the government is trying to ensure that the population that requires it and the one that will make the greatest difference have access to it. okay, so that the girl in Moyale can get the vaccine. Yeah. But it doesn't mean the vaccine is not available. If you would like to buy it, you can access it. Facilities actually offer the vaccine.
Yeah.
And it's provided. And I'm very happy we've moved to the single dose. I'm really, really happy because they lost the second dose loss was a little bit too high. And the third was even worse. Yeah. So you'd start like 50 people. By the time you're getting to the third dose, you're probably 10.
Which now the vaccine is not effective.
Yes. So I'm happy that now studies are showing that the single dose is as effective.
Yeah.
Yeah.
Okay. And now we have 3 vaccines that are available.
Yes.
There's a single dose.
Yeah.
Then we have the multi-doses, the Cervarix and Gardasil.
Yeah.
They cover different strains of HPV. For women who are above the age of 30, would we still say that the single dose should be recommended to them, or do we still recommend Gardasil to them?
So now vaccines are like, so the available vaccines are 3 types. So one is called Cervarix. And then we have Gardasil 4 and Gardasil 9.
Yeah.
Now, all of them have 16 and 18 for obvious reasons. And 6 and 11 for obvious reasons. We said the Watts, you still want to capture the Watts.
Yeah.
And then, of course, with studies have actually shown that it's just not 16, 18. We have a little bit more that are causing problems in different populations. So that's why we reached Gardasil 9.
Okay.
Yeah. But any of them is better than nothing. That's what people need to remember.
Okay.
Yeah.
Okay.
Yeah. So nothing is our problem.
Okay.
Access to any of them is actually good. Yeah. So Cervarix only had 16 and 18. And I think with the what problem, Gardasil 4 came in.
Yeah.
And they put 611.
Yeah.
Then Gardasil 9 and all that. I'm sure as we go along, we'll have Gardasil 14. I'm very sure. The vaccine world is not sleeping.
Oh, they're not. There's like, what else can we add?
Yeah. They're not sleeping. So I'm very sure at some point we will reach Gardasil 14. But what actually the research is actually showing is that even the 16 and 18 protects you a good portion.
Yeah.
Yeah. And you want protection. Protection is what we are looking for.
Yeah.
So we want your body to be able to fight the virus on exposure. And that's why we want the unexposed woman.
Okay.
Yeah. I think the unexposed one.
The unexposed one is covered.
Yes.
Let's talk about now the exposed one.
So there's a catch-up dose. We are still, it's still, so now, so for the Kenya guidelines, it's really an economic decision that you have to make.
Yeah.
We may not be able to afford to vaccinate everyone.
Yeah.
So what Rwanda is also doing is, because you can get the vaccine up to 26 guidelines, but they're saying even up to 40.
Yeah.
It's possible to actually get the vaccine. So it's a cost issue as opposed to, so cost makes availability a problem.
Yeah.
And then you're asking yourself, where can I actually make a difference? My 40-year-old is at the risk, is already in the bracket for the people I should screen.
Exactly.
So why can't I move
just
you
start
to
going for screening, please?
Yeah, why can't you just do screening?
Yeah. Okay.
So that's the thing.
Yeah.
But I think with time, when you look at the whole prevention methods that we have, if you vaccinate this population, as they grow older, their screening requirements may actually be less. Yeah. Or you may actually just screen and find nothing.
Yeah.
And also what actually the countries like Denmark, Sweden are showing is that because they had started giving the vaccine early, I think in the 90s or early 2000s, thereabout, I don't remember, they have a population where they're not even seeing a lot of 16 and 18. Yeah. So it's almost like, what do you call it? Herd immunity.
Herd immunity, yeah.
Yes. So herd immunity is happening, which is a good thing.
Yeah, it is.
So you screen this population to reduce the number of infections in the next population. Of course, there'll be 1 or 2 people who miss.
Yeah.
Always.
Yeah.
Yeah, but so screening becomes less in this population, or rather, the screening requirements will be a little bit less. Then when you move in to now the third place where we're having cervical cancer, you'll have less people.
Yeah.
So you can do a PET scan before and after, you know, because
you'll have less people and they'll be coming earlier. So you'll be detecting infection early.
You're going to detect these things much earlier and all that. So it just needs a bit more money down here.
I like how Australia did it. I was just looking at like their progression.
Yeah.
And they started the same way. It was more of like a resource issue.
Yeah.
And then at some point now they noticed actually we can reach a wider audience. And that's when they even included boys.
Yes. So now Australia started including boys. I think because I feel like they vaccinated every girl.
They're like,
they have the vaccine.
Any other girl, please. Any other girl first.
Yeah. But I guess I feel like they will really do reach elimination.
Yeah.
Yeah.
It's 2035. That's their target.
2030 is the actual WHO target. So
theirs is 35, I think.
Yeah. Total elimination.
Yes.
Yeah.
Not total. The 4.4. Is it 4.4?
Oh, yeah, 4. Yeah. It's 4.
Yeah.
Which is, wow. I really like that. I really do.
Speaking of 4.4, what is our standing of cervical cancer in the country? What are our numbers?
3,800 per 100,000. Like, we're really doing badly.
Yes, that's a big number.
No, I don't even think we should say it loudly. We're really doing badly.
I'll put it here. Yeah. That's a big number.
Yeah.
Okay. Now, in the past couple of years, because I think cervical cancer has become more of the talk, is there a difference we're noticing in terms of behavior change, where people are either a bit more receptive to screening or vaccination, or where are we a bit more reluctant?
So I guess over time we've changed how we did screening. So now, you see, screening was being offered at the facility. When you offer screening at the facility, the people who come into the facility are sick people. So they're coming for hypertension, diabetes, or maybe just coming to the gynae clinic, because that's where we offer it.
Yeah.
Or we are giving it at the MCH clinic, the maternal and child health clinic. And that clinic, everybody has an agenda. They're not coming to screen.
Yeah.
You have to offer it. Yeah. For them to need. And I can have various reasons. I need to be at work at 9. Or I need to drop the baby home and go to work. Or I need to open my clinic. I need to open my kibanda by 9. Like, I can have myriad reasons why I don't want to screen when I've brought my child for vaccination. So what we are changing is we are going out.
Okay.
So if you vaccinate in the community, you'll find them there. It will be much easier when it's in the community. We bring in the test and we still go back to the community to treat the ones who are positive, because you are going to have the precancerous lesions. Those ones can be treated in like mobile clinics. It shouldn't. You don't really need to bring them into the facility for you to be able to treat.
Okay.
Which is why I think medical officers have there's a good opportunity there. Just probably a mind shift.
Yeah.
That you don't have to be at the facility to make a difference. Yeah.
That's
at
true.
the facility, we have sick people.
Yeah.
In the community, we can do more prevention.
Yeah. And prevention is actually more effective in terms of resources, in terms of just longevity of life. Yeah.
Then also the campaigns we have around cervical cancer screening. Yeah. So you have your well patient. Like, for example, at SkinH, what we've been doing, the free HPV testing. So because it's been all over social media and all that, so you have walk-ins, which is a good thing, because it's not a sick person. Yeah. The sick person has other priorities.
That's true. That's true. Were you guys doing the self-testing, or
it's self-testing? It was self-testing. Yeah.
Are you doing it now continuously as part of your offerings?
I really do hope we will continue.
Okay.
Yeah, but we still offer the others.
Yeah,
just in case, because there's the person who will prefer provider-led screening.
That's true. Because I think if KNH is continuing to offer it, that's a good benchmark.
Really true.
Yeah, because
really
you're the ones everyone looks up to in terms of like the other smaller facilities. So I think that will be a good step. Okay.
The government, though, has been offering HPV testing, has been at least rolling it out.
Yeah.
HPV testing within the counties.
Yeah.
So it's just, support, to allow it to take up. Yeah.
And I think that's a good thing, because even now, as you mentioned, things are changing, and there's now the switch from pap smears to HPV testing as the main screening. The question was, do we have the capacity in terms of our health system to offer HPV testing at cost, where I'm not feeling like, guy, that's so expensive, because we know it was expensive.
Do the other one.
Yeah, if you're looking at the HPV DNA test versus a pap smear, in some places it's worlds apart in terms of cost.
I totally agree. I agree.
In terms of cost. And then also now, insurance, is it covered in, we have of course the insured population, is it covered? Does SHA shift and the likes? Do they cover it? Like, there's still so many questions, but at least it's a step. At least it's a step.
It's there in the document. I pray that they can actualize it. Remember,
we said we are good on paper.
We are very good on paper, and I understand why we are good on paper, because you really need to write things that you can do.
Yes.
Yeah, so it's the money thing. You just need to be able to provide the money to support that kind of screening, so that if I come to my village and I want to screen and everybody is SHA compliant, I should be able to screen without feeling like telling the woman, you need to pay 3,000. Not everyone has that amount of money. Really, there are priorities in everybody's life that make screening come lower down as a priority.
That's true.
Yeah, but I think the cost will come down. I think, because the more available the test is, the more likely it's going to be affordable.
Yeah. So now it has to be consumer driven.
It has to be consumer driven.
Yeah.
And also, if you just avail, in the economies of scale, you can either increase demand to change the cost or increase supply to change the cost. So it's both sides. If you do both, then chances are the cost should come down. And it has come down over time. It was much more expensive.
So how much is it roughly right now? I think I was looking at
it varies. It's about 5K.
In some places.
Yeah.
I think I was seeing the range is 5 to 9. Now, depending on where you go.
Depending on where you do it. Yeah.
And the same for the vaccine. It's like between 3 and 7, 9.
Yes, depending on where you go. Yeah. But the Gardasil 9 is very expensive.
And then if you're doing HPV, because they say, especially if you're over the age of 26, you do HPV testing and then vaccinate. Sasa, you've done the test, they've told you 9,000 shillings. Insurance is like, even as you don't cover that one. Then now your gyna is like, actually now we can actually vaccinate you. And because we want you to be covered, Cindy, let's do the one that covers everything. 14,000 shillings.
It's not 14.
No,
it's 40.
It's 40. 40.
40. That's Gardasil 9. Gardasil 9. But remember what we said.
Yeah.
Any vaccine is better than no vaccine.
That's true.
So if what is available and acceptable to you is Cervarix, please do it.
Okay.
If it's Gardasil 4, do it. We are not saying that we break an arm and a leg to access vaccines. We are saying, let's make it acceptable and affordable. But also remember, if the demand for Gardasil 9 goes up,
the price goes down.
The price will come down.
And the price will be right.
Yes. Yeah.
But also now seeing that Gavi has also reduced its...
Won't everyone do?
Wait. I mean, our funders, not our funders, the people who help us are also having some challenges.
Yeah.
We also need to pick up. We need to pull up our socks.
I think it's about time.
It's about time we pull up our socks.
We did in-house support for our agenda.
And we can do it. The thing is, we can. The amount of money that's been lost every single day.
Yeah.
We can
just need to want it.
Yeah.
We haven't wanted it much.
Yeah. So now we need to want it more.
We need to want it.
Okay.
More. Yeah.
Okay. Sawa. Now, before we are wrapping up, I know it was a great discussion. Before we wrap, maybe what are some symptoms of cervical cancer now that we need to look out for? That's one question. And then the other question is, if you were to advise someone on how to prepare for screening, what would you tell them to do?
I actually can't believe people worry about preparing.
Let me tell you,
anyway,
people panic.
If possible, just... let's avoid the menses bit, because people's menses are different. There are people who it's very heavy. So if it's very heavy, even if I do the HPV DNA, it will be just full of blood. I'm sure I can get the virus, but just to make it less messy and more acceptable even to the person. You see, it may not bother me. That's what I do every day. But it can bother the other person. But imagine you don't need to prepare.
What about sex and activity?
You don't need to prepare for cervical cancer screening.
Okay.
Anytime is good enough.
Okay.
Yeah.
You heard it from her. You heard it from her. So please, if you haven't screened by now, the time is now. Actually, the best time was yesterday, but we can still do it today. Yeah. Okay. Symptoms.
The symptoms
to look out for.
So now we agreed we have pretty much no symptoms. Even in very early cervical cancer, you may not have any symptoms. So in terms of symptoms, just starting from the simple ones, moving to the very complicated ones. So the one common complaint is about discharge. So vaginal discharge. That's really foul smelling.
Yeah.
And
do you find like it has a distinct...
Yes, it does.
Okay. I was just making sure it's not just me.
No, it's not you.
Yeah.
It has a distinct smell.
Yeah.
And that's because it's tumor. It's tumor, like breaking down.
Okay.
Yeah, so that's why you have that particular discharge. So one complaint that I find people generally come with, they'll be like, I've had a discharge for like a year and now it's become watery. And now when I just walk around, I can feel this smell that's not going anywhere. So that's one. And then the other one where I find people don't talk about a lot is bleeding after or during sex. So you find every single time there's bleeding, you know you're not on your menses, but every time you're seeing blood. So that's a sign.
Okay.
There's something there. There's a tumor inside there that we need to look at. So the other thing is pain, because as the tumor spreads, it starts pressing on other tissues. Of course, it doesn't obey the rules of cell multiplication.
Yeah. It goes
so what happens?
Anywhere.
Yeah, it's anywhere, everywhere, and all that. And it starts pressing other organs. And so pain is one of the things. Just pain that's not going anywhere needs to be looked at. And then as it goes on and on, you start having... So you have the pain. So if it's compressing the kidney, you can actually present with kidney failure.
Okay.
Yeah. If it's compressing the blood vessels, you can actually present with a clot in the leg. If it's compressing the back, or if it's spread to the back, you can present with just plain backache. So like a backache that's going nowhere.
Yeah.
Yes. So essentially, those are the basic complaints around cervical cancer. So you have, your pelvic pain, the discharge, the bleeding. And one of the things I find, especially women who are in the reproductive age, like the 21 to 45, they're women, you find because they have menses every particular month, they're not able to say that this bleeding, okay, I know it's abnormal, but maybe they think, okay, maybe it's one-off. So you really shrug it for a very long time, but the postmenopausal woman will come. The very first time they see bleeding after sex, they'll come.
Like, I thought you went away.
Yeah, I'm
are you back?
Why am I bleeding? Why am I...
Yeah.
But in between here, you find people rationalize the bleeding. So they'll say, oh, my family planning is probably acting up.
Yeah.
Oh, maybe it's because I'm breastfeeding. My period will not be regular. So there are many excuses in between. But any bleeding that just doesn't follow your normal menstrual cycle needs to be looked at.
Yeah.
So that we have less people ignoring that. Anytime you have a discharge or bleeding or anything like that, it's good for people to go and see their doctor, and please request for a vaginal exam. I don't know why.
Say it to the camera.
Yeah. Request for a vaginal exam, i.e. the speculum. Because seeing is believing. If I see something inside there, I'm likely going to do something, as opposed to when you tell me you're bleeding and I tell you take this medication, I haven't helped you. So reproductive health problems, we really need to look at the cervix in any way. Anyway, please have your cervix looked at. Yeah.
Okay. Sawa. Now, to wind up, let me just go to my questions. So now we started in the doctor's seat. Now it's beyond the clinic. If you had a time capsule, okay, no, it's instead of a time capsule. If you had to text one simple, actionable health tip to all your patients right now, what would it be? Just one.
One tip.
Yeah.
I would say your diet prevents a lot of things. Be keen on what you eat.
Okay.
It either empowers your body to kill disease or not.
Interesting. Okay. And on that note, number 2, what's the first thing you do for yourself, either in the morning or the last thing you do at night that's just for your own sanity?
So at night, I, by myself, just purely by myself.
Just by yourself, for yourself. Like it's
for
just
myself.
For your sanity, your peace of mind.
So what went wrong? What went right? What's the one thing I need to do better tomorrow? Yeah.
So you reflect.
Yes.
Okay.
Yeah.
I should start
Not
doing
too complicated.
That.
Just simple. What did I... And because sometimes you wake up with like 10 things. Even when you're writing them, you know you won't reach number 10.
Yeah. Yeah.
But what's the one thing I envisioned to do, and I did it, and I did it well? What did I want to do, but it didn't go well? And what's my take home about that particular thing? Can I do it better tomorrow? Yes, I can. Okay. How can I do it better? Yeah.
Wow, that's so interesting. I've tasked myself this year to learn something new every day. So I've learned that one.
Yes.
Yeah.
You do self-audit every day.
Self-audit. Sometimes you don't want to audit.
Sometimes I ask myself, what did I say that wasn't nice? Or what did I say that was actually good? Then I look back and I was like, that was a good thing I did. Yeah.
So it informs you tomorrow.
Yes. Yeah.
Okay. Then was there a moment recently with a patient or in your training where you thought, and the body is just wild? Like, why would you do that?
Like in what way?
Like for me, let me give an example. Anytime I hear something about pregnancy, I'm just like, why do I have to lose teeth? Like, why?
Yeah. Not quite. Not really quite. No, I can't think of something like, why would someone do that?
Why would the body do that? Yeah.
Yeah, so one of the things that I really feel so bad about is when I have this patient who exercises, watches, not really, literally watches their weight, but is so keen on having a good body outlook. They're high on energy. They show up for screening every year. And then they have a cancer. Like,
yeah, it's unfair.
I'm like, it's not fair.
Yeah, I agree with that one.
I'm like, it's not fair.
I 100% agree with that one.
Yeah, that one is
That's
painful.
A good one. And I think being an oncologist, you see that a lot.
I see that a lot, and I'm like, it's not fair. Yeah, this one they've done everything right, for real.
Maybe that's one of the questions, just like, and God, when I get there, I just have to ask you, why that one?
Yeah, I know, because you're like, it's really, like, I remember there was a family friend of ours.
Yeah.
She had decided to, change her diet. She was pretty elderly by the time she was doing that. But she was hanging out with her family, her children and all that. And they were living out of the country at that point. And she's like, all these things are available. Why am I eating badly? So she changed everything. She lost some weight. Of course, everyone was like, why were you looking like this? She's like, no, I actually, I feel better.
Yeah.
And then she got cancer of the stomach. Imagine I couldn't make peace with that thing. I was like, God, it's not fair.
Yeah, it's not fair.
Yeah. So that's the hard bit.
Okay. I think that's a good one. What's a piece of health advice you gave 10 years ago that you've changed your mind on?
Okay, some things I can't even say on there.
I was trying to think.
What did I say 10 years ago? I think 10 years ago, I would tell people just probably get your babies and all that. But then when you start getting children, you realize, people need to space like a lot. A lot.
Okay.
This thing is crazy.
Yeah.
You lose your mind, you lose your time, you lose yourself. Like,
Yeah. I just saw on social media, there's a lady who said she became schizophrenic after getting her baby. And I was just like, honestly, no. No, you can't. Why?
No, you can. So I always tell my friends about this thing because I try to explain it to my husband and our friends, and it just doesn't go down well.
Yeah.
It's about mental load. I tell him when I enter the kitchen to pick a glass of water. If we both entered, he most likely will pick the glass of water, switch off and walk out. I will reach the kitchen and I'm like, do I have snacks for the kids for tomorrow? By the way, is there a school activity? Have I bought all the groceries? By the way, is there lunch for tomorrow? No, we need to eat a salad. We need to eat a salad. Oh, wait a minute. Are their clothes still fitting? Are they sleeping well? Why is the other one sounding like they're screaming? And this is just me walking. And then maybe I find things along the way. So I pick like the basin or the bucket.
Yeah.
I'm like, oh yeah, that bag. Then I sit, I'm like, it's old. I need to order new buckets. The price of buckets has gone up. Can my money actually fit this thing? So I literally have a conversation after and I was just going to pick water.
Can I tell you a funny story? I saw someone who was actually saying, And he wasn't saying the problem with women. He was just saying something he's noticed about men versus women is men literally act and think about themselves first.
They always do.
Yeah, for a woman, you think of everyone else first, then you. So he was like, sometimes women need to be more selfish and sometimes focus on you.
It's true, but you really have to be intentional to do that. It's the same thing. I was watching a video yesterday of a family. There were like 5 kids seated on the couch. The husband and the father and mother are seated. And the man walks out. The kids adjust. They come and sit properly around their mom. So the guy comes back. They all move. He sits down. Then they stay for like 10 minutes. And then their mom moves. They left.
They follow her.
I was like, that sounds like my children. I'm like, that's the problem. Because now if I go with them, one will start asking, I'm hungry, mommy. And maybe I just wanted to go pick a glass of water.
Yeah.
Just a glass of water.
Now we need to share the load. Share the load. Okay, last question. What's a health rule you think we should all break a little more often without feeling guilty?
I think everyone should have a thing they enjoy eating that is not, like, it's not acceptable, but once in a while you should do it.
Yeah.
Not like every day, every weekend, just once in a while you should just live. Without worrying, I'm going to gain 5 kg. You know, my sugar is going to go like this. No, there should be just that one thing that is a reward for just good behavior.
I think mine is we should have at least one inactive day. Like inactive. Like you just stay in bed the whole day.
You don't have an inactive day?
I do, but every time I have it, I'm just like, okay, fine, stand up, DVT. Okay, fine.
I think everyone should have an inactive day, one inactive day during the week.
Yes.
Every week.
Yes, I 100% agree.
And we should move to 4 work days. I don't know why we are doing 5.
Speak to the camera.
Yeah, we should move to 4 work day weeks. What is the problem? I think when you have a 5-day work week, and then the weekend, one day is for cleaning up the house. The other day is for taking the kids to church and to hang out with them to know whether they eat rice or they eat ugali or they don't. I don't think you've rested the whole week. Yeah, so it becomes a copy of this week. Next week, there should be one day where you stop and do self.
Yeah. I agree. So we'll discuss that in the meeting next week.
Yeah, you should.
Now, just to wrap it up, what is your parting shot? So to the government, please put in money in prevention. There's no amount of paperwork, policies, guidelines we are going to write. And if there's no money, we really are going nowhere. Like the woman in my village should be able to know that SHA Shift covers the HPV test that I want. I'm telling them. Then the second thing for the women in the community is that let's learn to prioritize our health. A healthy woman is a plus for the family. Like a plus that entire village, that entire community is actually very important. Now to the men, much as we have never spoken to the men about cervical cancer screening, I think it would be good if we support our women and nudge them to screen, at the very least every year. Yeah. Okay. I think that's it. I won't add on anything. Thank you so much for coming. Do you want to be found? Are you on social media? Do you want people to find you? Do you have a private practice? Do you want people to come to you? You can plug something.
Oh, yeah. So I do run a private practice. It's called Janice Medical and Cancer Hospital. So my clinic is actually there. So on and off, I do see private patients at Kenyatta National Hospital. So both places, you can actually find me. I admit in many hospitals. So yeah, look for me.
We'll put the information somewhere so they can access
it. I'm on LinkedIn.
You're on LinkedIn?
Yes.
It's giving millennial.
No, I'm on social media. It's just that.
No, it's fine. Maybe your social media is just for you, and that's okay.
Yeah, it's actually for me.
It's fine. It's fine. This year, Usifos.
It's true. It's true.
Yeah. But that's it for us, guys. Thank you so much for listening to this episode. If you've reached this far, please be sure to like, to follow, to share. Please leave a comment in the comment section below about maybe what you've learned, something you'd like to see maybe change in our cervical cancer practices as a country, or just some aspirations you'd want for us to better our health. Also follow us on our socials on, I was going to say LinkedIn, but you can follow us on LinkedIn, but TikTok, Instagram, where else? Spotify.
You on Spotify?
Spotify, Apple, Amazon, wherever you listen to your podcast. So this was a lovely session, and see you next time. Bye.